Good afternoon, everybody. My name is Michelle Brunson. I am a Health IT Advisor here at Telegen for the Small, Underserved, and Rural Support Quality Payment Program Resource Center. Presenting with me today is my colleague and friend, Sandy Swallow, the Quinn QIO Health IT Advisor. Sandy works with groups of 16 or more clinicians and larger health system ACOs. So thank you for joining us today to learn how to survive and thrive in the improvement activities and cost categories of the Quality Payment Program, also known as MACRA. We hope you discover some tips to take away today that might make your navigation a bit easier. And we do want to note that unlike many of the other MIPS or Quality Payment Program webinars, today's webinar we're going to focus solely on these two categories without much of the basics of the program. So if you do need that background information, there are some great resources on CMS's QPP site, and we provide those links at the end of the presentation on our resources slide for your reference. Before we begin the webinar, though, I do want to talk a little bit that on Tuesday, June 20th, CMS released a proposed rule for calendar year 2018 Quality Payment Program updates. CMS's goal is to simplify the program as much as possible, especially for that small, underserved, and rural practices, while ensuring fiscal sustainability and high-quality care within Medicare. I have a link here for the both the fact sheet, which is in a nice table format, comparing 2017 rules to the 2018 proposed changes. And I've also included a link to the actual proposed rule. I want to point out that comments on the rule are due by August 21st at 5 p.m. Eastern. And so if you would please take a look at the fact sheet and then proposed rule in more detail. I'm including instructions on how to submit those comments electronically, but also on page 2 you will see how to mail in your comments. So you have options there, and we just want to make sure you're all aware of this. And while we have not had time to read the final rule, we have had a chance to look at the fact sheet mostly for both the improvement activities and costs and in preparation for this webinar. So while we're going through the webinar today, we'll try to interject some proposals for your awareness. Again, that is just a proposed rule. After talking briefly about the Quality Payment Program categories and their weights, I will talk more specifically about the improvement activity category with a lot of emphasis on the basics, as this is a new category in 2017. And then I'll provide some scoring examples and tips to keep in mind. Sandy then will talk about the cost category, focusing on the requirements, patient attribution, proposed episodes of care, and finally some scoring basics. And finally, we'll connect the final score to the MIPS payment adjustment so we can tie it all together for you. So as you know, the Quality Payment Program has 4 different performance categories, 3 of which will be used for this 2017 transition year. You will receive points for each category to come up with your final score. This score is measured against your peers to give you a payment adjustment in 2019 for this 2017 performance year. There are 3 categories to be used for this transition year, and those are quality, advancing care information, and improvement activities. That 4th category, cost, will not be calculated into your final score in 2017, but it will be here in the near future, and so as we're almost through 2017, we thought it would be a good idea to start talking about this so you start becoming familiar with some of the concepts. You will see the weight for each category under the category name, both for MIPS-eligible clinicians as well as for those clinicians in a MIPS alternative payment model. And notice that for MIPS ATM, there is some more weight given to the advancing care information and improvement activities categories, with less for quality. Again, cost is not factored in for 2017 for either of those participating in MIPS or MIPS ATM. So today, we're going to focus on both the improvement activities and costs, and as I just mentioned, since cost is not a factor, we do want to give you some background for the future. Okay, so let's start off with that improvement activities category first. This category accounts for 15% of your final score in this 2017 transition year for those participating in MIPS. Or if you are participating in a MIPS ATM, it will account for 20%. These improvement activities assess your participation in activities that improve your clinical practice, really looking at evolving into a patient-centric approach. There are many activities, 92 to be exact, from which you can choose. If you are in a certified patient-centered medical home or advanced alternative payment model, you're in a good place, and we'll describe why in a second. All of the improvement activities are weighted, either medium or high weight, depending on the level of difficulty or maybe the level of importance. And so if you were to complete a medium-weighted activity, it is worth 10 points. If it is a high-weighted activity, you will score 20 points. There are some special considerations, especially for those in small, underserved, or rural practices with 15 or fewer clinicians, like many of you today on the call. So I will discuss how your points are scored in a minute. So again, to receive that maximum score, you will get 40 points. So in the 2018 proposed rule, there is no proposed change in weight to the final score for either the MIPS or MIPS ATM submissions. And CMS is also proposing more activities to choose from and changes to the existing activities in the inventory. The improvement activities for the first year of MIPS are divided into 9 subcategories, and you'll see those listed here. And when you look at these subcategories, you can see how the improvement activities category focuses on improving your clinical practice with the patient in mind. Now, one thing to note, there are no subcategory reporting requirements. So you can select activities from any of these subcategories. Likewise, all of your activities can be from the same category if you wish. As I said, there's a maximum of 40 points, with high-weighted activities receiving 20 points and medium-weighted activities receiving 10 points. But one thing to note is there is a 90-day minimum required for all improvement activities. And what this means is that you need to start incorporating your activities no later than October 2nd to have a total of 90 days for that activity if your performance period is October 2nd through December 31st of 17. There are different reporting options, either through a qualified registry, your electronic health record, qualified clinical data registry, or if you're in a group of 25 or more, the CMS web interface. Now, there are no documents you will submit when you attest or when you let CMS know that which activities you are implementing into your practice. So you will need to keep all of your documentation proving your implementation of that activity for a minimum of 6 years in the event of an audit. And we always recommend to keep both paper and electronic versions of your documentation. In the 2018 proposed rule, there's no change in the number of activities that MIPS-eligible clinicians have to report to reach a total of 40 points. Now, as I briefly mentioned a bit ago, there are some special scoring considerations. First of all, if your practice receives certification from a nationally recognized certifying agency that you are a participant in a patient-centered medical home, you will automatically receive the maximum possible points of 40. Secondly, if you are a participant in an alternative payment model which has been designated as a medical home model, CMS will decide if you receive 50 to 100% of your maximum points. You will automatically receive points based on the requirements of participating in the APM. And for all current APMs under the APM scoring standard, this assigned score will be full credit. For all future APMs under the APM scoring standard, the assigned score will be at least half credit. And I'll talk more in detail about this in the next couple of slides. Finally, there's an alternate activity weight for special populations. And as I mentioned briefly before, those who are in practices with 15 or fewer clinicians, rural, underserved practices, or with non-patient-facing clinicians or groups, those special populations have an activity weight that's more than the other populations. So, for example, a medium-weighted activity, instead of being worth 10 points, is worth 20 points. And a high-weighted activity is worth 40 points. So to meet this score, you may just need to complete then one high-weighted activity or maybe 2 medium-weighted activities. And again, many of you on this call are in that special population, so that's why I'm drawing this out. Now, in the 2018 proposed rule, MIPS eligible clinicians in these small, underserved, and rural support practices will keep reporting those 2 medium or 1 high-weighted activity to reach the highest score. And they are looking to expand, or proposing to expand the definition of a certified PCMH to include the CPC Plus alternative payment model. And they also are looking to verify that the term recognized is the same as certified in reference to the patient-centered medical home or comparable specialty practice. And finally, the threshold of 50% of the practices within a 10 that need to be recognized as a patient-centered medical approach for the 10 to get full credit. So some of those that are staying the same and some that are looking a little different. Now, CMS derived the assign points for each of those MIPS APMs by reviewing the MIPS APM's participation agreement and or their relevant regulations to determine the improvement activities required as a function of participation in the MIPS APM. And the list of those required activities for each APM was compared to the MIPS list of improvement activities for the 2017 performance period. APMs hold their participants accountable for cost and quality of care provided to their Medicare beneficiaries. So CMS is currently assigning full improvement activity score by virtue of just being in an APM, and there is no additional reporting necessary. So these practices won't have to submit additional improvement activity information or attest to that. APM entities participating in the MIPS APM will receive that same baseline improvement activity score in which they participate. And in future years, credit for the APM participation may drop to 50% for APM participation. At the end of the webinar in the resources slide, we have included a list of the improvement activities and subcategories with its weight. In the 2018 proposed rule, they don't have any proposed changes to scoring for the APMs or MIPS APMs. Now here's a list of those MIPS APMs for the 2017 performance period whose participants will receive full credit. And I won't go through those, but you can see there are quite a few there. If you choose not to select any activities or you don't perform them for at least 90 days, you aren't participating in an alternative payment model or in a patient-centered medical home or comparable specialty practice, you will not score any points for this performance category. Now, I wanted to show you how to access the improvement activities list on the CMS's Quality Payment Program site. They recently updated their website, so it's such a great source of information, and they're continually adding resources. So we strongly encourage you to go out there and look at it often, especially under the resources. It's under the About section there. And since we're talking about improvement activities today, I want to show you where you would go for this list. So after you go to the site, you click on the MIPS drop-down in the upper right-hand corner, and then you choose Improvement Activities. That will then take you to the Improvement Activities piece of the site, and you can see that picture on the left what that looks like. And so there are 92 listed there. And after you choose the activity, you will see that there's a description. And once it expands, you'll see that not only is there a description, but there's also the activity weighting, the subcategory name, and its activity ID. As I said, there are so many different activities. It's well worth your time to go through those in detail on the QPP.cms.gov site to review the entire list and choose those activities that are best suited for your practice. But I've included a list here of some of those more popular activities it seems like my practices are choosing. Again, this is just a tiny sample. By no means I'm suggesting these, but I just want to give you an idea of the variety available. And you can see how they touch the different subcategories, all with the patient at the center. And looking at these for this webinar preparation, I realized that there are 4 different subcategories represented here: patient safety, achieving health equity, care coordination, and expanded practice access. And 3 of those are high-weighted activities. Those are consultation of the prescription drug monitoring program, or engagement of new Medicaid patients and follow-up, and finally providing 24/7 access. Now I want to go into some scoring examples because I always feel like that's helpful to see. So the MIPS eligible clinician who is in a practice with greater than 15 eligible clinicians again, everyone has to earn 40 points in this improvement activity category to receive full credit of 15%. And each improvement activity is worth 10 points for medium-weighted or 20 points for high-weighted activities. So all but for those special populations, and we'll show an example of that as well. So to show you how this scoring example works for this practice of more than 15 eligible clinicians, this practice has 3 different activities that they realize they are doing. And so in preparation for what they wanted to choose, they looked at those. And the first one is the improvements for timely communication of test results. That's a medium-weighted activity, so they get 10 points. The second is engagement of new Medicaid patients and follow-up, and that's actually a high-weighted activity, and so that's worth 20 points. And then they realized that they also provide 24/7 access to care, and that's a high-weighted activity. So there's 20 points there too. So if you were to add these up, you get 50 points. Now, is there a possibility that you could score more than 15% if you complete more improvement activities? And the answer is no. That there is a total possible points of 40 points. And so if they divide the number of points by the number of total possible points, you'll see they scored 125%. But it is capped at 100% of 40 points. So you take that times the 15 possible composite category points, and you will see that they get 15 composite category points earned. Now this next example, you can see that it is for a practice with 15 or fewer clinicians. And so they are one of those special populations with the special scoring. And so they receive double the points of the normal activity weight. So they are enrolled have an annual registration in the prescription drug monitoring program, and that's a medium-weighted activity. And then they also participate with the Transforming Clinical Practice Initiative, or TCPI, and good for them. So they also have a high-weighted activity of 40 points. Now, if you add those up, of course, it's more than 40 points. It's 60 points. And so they're at 150% of their category weight. But, again, the max they can earn would be 100% of that cap of 40 points, so they earn 15 composite category points earned. Now, as participants in an APM, for the 2017 performance year, CMS has deemed special and MIPS APM scoring a full credit for the improvement activities category, or 20% for them. Because if you remember, they are weighted a little bit higher in this improvement activities category. So, again, CMS derived those assigned points by reviewing those MIPS APM participation agreements, and they determined that the improvement activities required are a function of participation in the APM, so they get full credit for that. Now, for this last part of the improvement activities category piece, we wanted to pull together some tips that we thought might be helpful. And, again, maybe you understand this, but in talking with our practices, we realized some people could use a little direction in this since it is a new category. So, first of all, of the 92 activities, there are 14 which are high-weighted. So I suggest you start here to see if you might be implementing part or all of the activity already, and you would have less work to fully implement this activity. And if you happen to get to choose a high-weighted activity or your practice with 15 or fewer clinicians, you wouldn't need to work on another activity. So otherwise, if you have 16 or more clinicians, you would just need to report on one more high-weighted or 2 medium-weighted activities. Now, another point to keep in mind is there are 13 activities of the 92 with which a qualified clinical data registry is emphasized. So, if you haven't reported your quality measures before with the Legacy PPT-SURS program, and you're considering different submission method options, even if you've used another method before, you may want to start with the Qualified Clinical Data Registry to start looking into what would be involved and what are the costs with that to see if that's an option for you. We've spoken with some practices that for whatever reason want to submit just for the test-based option by submitting one activity. They might not be ready quite yet to fully go into the quality payment program through the MIPS path. So if this is the case, many times we're suggesting that they look at the improvement activities category first and select one of those improvement activities, either that they have already implemented or they can implement for a minimum of 90 days. And if you select one of those, then you would be able to go out to the CMS's portal to attest that, yes, you have implemented this activity for the 2017 transition year, and it's at no cost. So that's a big factor for those choosing to use the test-based option. And there are lists of those activities for MIPS APMs you want to review for next year if CMS does give only 50% participation in a MIPS APM as well. And you'll see those on the resources slide. So a couple other points to point out with the 2018 proposed rule is that they want to keep allowing simple attestation of improvement activities. So that in the proposal is proposed to keep the same of that attestation through the CMS portal. And still only one MIPS eligible submission in a TIN has to perform that improvement activity for the TIN to get credit of choosing that group reporting method. So CMS is soliciting comments on alternatives for a future threshold. The next tip is to make sure you implement your activity again for at least 90 days. So begin now to drill down to those activities that you may want to use or are using if you haven't done so already. Review that whole list, looking at all of the descriptions, and bring in those that might be of interest to your team. Discuss those and how you would implement those activities. And finally, but certainly not least, decide how to document activities for proof. So that way, if you are ever audited, you can provide that documentation up to 6 years later. Now, for documentation, you want to look at each activity on its own to determine what documentation you could provide to that auditor to show examples of how you have implemented this activity. For example, it may be a documented policy and screenshots of your website with your extended hours showing for the activity of providing 24/7 access. And it may be a policy and agreement you have with an organization. So whatever those examples are, look and you really want to just provide no question of this is how you implemented that activity. And it may be showing before and after screenshots as well. So just another reminder, keep your documentation for those 6 years electronically and on paper. Now, also you will receive 10% bonus points in the advancing care information category if you submit your improvement activity, just one has to be submitted, using your certified EHR technology. And so on this next slide, I know this is extremely small print, and I apologize, but just so you know that there are 18 of the 92 activities available to report through your certified EHR technology, and these are listed here for your reference. But the main point of providing this to you is to notice that not all the improvement activities can be reported using your CHR technology, and you would also want to talk with your EHR vendor to make sure that they can report those improvement activities using your certified EHR technology. That's why there are bonus point opportunities for that advancing care information category. So start looking at this list. Maybe you'll see some that you can implement that will automatically then, if your vendor is able to do so, give you 10% extra bonus in the ACI category. Now I'm going to turn it over to Sandy, and she'll talk to you about that fourth category, cost.
Well, thank you, Michelle. I always love to follow Michelle. She's so much fun to work with, and I had a lot of fun when she's giving her webinars, too. And I love that she stuck me with our favorite category, the cost category. And I don't want you guys to let that 0% scoring fool you into thinking that you can relax on this category, because the cost becomes a factor just right around the corner in 2018. Now I'm going to say there's a caveat to that. As Michelle mentioned earlier, the QPP proposed rule for year 2 was released on Tuesday. One of the big changes that CMS is proposing will be the 0% weighting of the category, the cost category for both 2017 and 2018. Now, 2019, you'll just jump right into a 30% overall weight. So if they do decide to integrate the scoring for cost category not until 2019, you think about it, that's right around the corner too. Now, from my understanding, the recommendations to delay this is what they want to do is they want to allow for us, for you folks, to get some exposure to the new cost measures before they really have a significant impact on their overall MIPS scoring. Today we'll talk about those new cost measures, and we'll talk about the rule as we know it now. So moving on to the next slide. So again, as I said, what I'm going to do, these slides are developed, and what I'm going to talk to you about is as we know the rule now, where the 10% scoring takes effect in 2018, okay? I also want to add a disclaimer here right up front. I am not proficient in this area, and what I'm sharing today is how I understand it through reading the macro legislation and the conversations that I've had with experts in the field. There are many variables to this category and still some unknowns. A lot of things are still in development. So what I'm going to provide is kind of a high-level overview of the cost category and those cost measures as we know it now. Okay? So we know that in 2017 it's weighted at 0, and CMS intends to begin adjustments under the category beginning in 2018 when it'll be weighted at 10% with an increase to 30% by 2019, which means for the payment adjustment year 2021. Okay? So that means for 2019, 30 of the possible 100 points will go towards the MIPS score, the cost category's MIPS total score. So that's pretty significant. So that's why you can't relax on this. You really need to start learning about this and how it can affect and impact your MIPS score. Now, all the measures are going to be calculated by CMS on the administrative claims that are collected for a full calendar year, so there's no separate reporting that's required, so that's a nice positive for you folks. CMS will provide a feedback report based on the 2017 claims data. This is going to be similar to the QRUR. They do intend to make it a little bit more user-friendly. They want it to be for you to be able to use the information on the cost feedback report to target areas for improving your cost for which the eligible clinicians are directly responsible. There are some things that you are not going to be directly responsible for that you can't change. Okay, so before we talk about a couple of significant changes in this category, I want to remind you of the old legacy programs, PQRS and the value modifier program scoring. This is considered what CMS considered quality tiering scoring, and the programs were combined to get their overall cost scoring for the QRUR. Now, in MIPS, the quality category replaced the data submission of the PQRS clinical quality measures, and it's scored separately by itself, but it also, along with the quality measures that you submit, you're also being scored on the all-cause hospital readmission measure. And we talked about that in our quality category, in our quality webinar. So that all-cause hospital readmission measure will not be part of the cost category. That's part of the quality category. Now, in that all-cause hospital readmission measure, it only is applicable to the larger groups. I think it was either 15 or 16 or more providers. Now, while the cost category now in the MIPS program, it takes over the total cost per capita, the Medicare spending per beneficiary measures, and episodes of care measures for scoring, and we'll break those down here in another slide or two. There are a couple of significant cost changes that you should be aware of are the attribution of patients changes and the cost comparison methodology changes. So in quality tiering, beneficiaries were attributed by the 10. But in MIPS, the attribution will be at the individual MPI level to the primary care provider. Now, I'm not really sure how this is going to affect your numbers, as there's really, I can't find any mathematical prediction in favor or against that for you. Just know that you'll be looking at probably a different set of patients when you're looking at your feedback report. So what that means is, really is that they will be looking at the primary care provider that provides a plurality or the highest number of visits or the highest volume dollars, and that patient will be attributed to that MPI number. So it used to be accumulated by the 10. If the patient saw multiple providers in that 10, they were attributed to the 10. Now it's going to be by the individual primary care. So again, you can expect to see a different set of patients attached to your practice. It's going to be the loyal patients that you can expect to see on there, the patients that come back to your office over and over. And in my opinion, this is better for you because those are the patients that, as an eligible clinician, you can have more control over who that patient sees and where they go for their services and the risk of duplication of services. Now, let's just say the patient makes no visit to the primary care provider in the performance period. Then this goes to the specialist with the highest volume. So maybe that patient has some pretty significant chronic conditions, and he or she, that Medicare beneficiary, sees a specialist, and that specialist not only takes care of their chronic, those conditions, but pretty much all of their basic care, and they don't ever go to a primary care provider, then that specialist is going to get that patient attributed to them. Now, the other big change in this cost category in the value modifier quality tiering, it was compared on a standard deviation of the mean, and now it's going to be on a decile ranking and scored based on deciles. Again, I'm really not sure how this will affect your scoring. There's no real prediction out there that I can find, but that's just a change that you should be made aware of when we talk about how this scoring methodology happens. Okay, as in the past, there are risk adjustments that will apply. Numbers for cost are adjusted geographically by the geographic location modification within the fee schedule. You guys are familiar with that. You're used to that. Then the hierarchy condition codes, you're used to those. They've been using those for years to modify in the Medicare Advantage payments and the value modifying quality tiering. And also the specialty adjustment is still being applied, but it's only going to be applied to the total per capita cost measure. So let's talk about those cost measures. As we know it now, there are three areas of cost measures for MIPS. The total per capita cost for all attributed beneficiaries, the Medicare spending per beneficiary, or MSBP, and the episode-based measures. So generally speaking, a cost measure represents the Medicare payment for items and services furnished to a beneficiary during an episode of care. The episodes of care and patient condition groups and codes will be pulled from the claims from trigger points, such as maybe there was an inpatient stay, that's a trigger point, or a diagnosis code can be a trigger point. But when you're looking at the total per capita cost, this is the annual cost per beneficiary, or the global health care cost that Medicare spends on that beneficiary, and then it gets attributed to a single primary care provider. Now, CMS made that change because they want the cost to apply to providers if a provider submits individually. Now, say if your providers and you're submitted as a group, or like a GPRO, they will take the aggregate of all the individual MPIs, beneficiary attributions, and they'll tie those into that 10, and then that group of patients will be your 10s, will be who your 10's responsible for, who that feedback report is going to be on if you're reporting as a group versus as an individual. So again, the patient gets tied to the NPI number. They add all those NPIs, beneficiaries that are attributed, and put those all together for that 10. Hopefully that makes sense. Michelle's shaking her head yes, so okay, good. Okay, so let's talk about the Medicare spending per beneficiary. This has been around a while too. It includes the charges attributed to the inpatient stays for the beneficiaries that are attributed to a provider or group with a plurality of the inpatient charges. Now, this is not just a primary care provider. This is where the specialist may see some significant changes because most often it's not the primary care provider that's going to be seeing the inpatient stays. Also with the MSBP, the case minimum dropped from 125 to 35 for them to evaluate. Now, the last area of cost measures is the episode-based measures. They're adding a lot of episodes of care measures. Right now they're tracking 40. 10 will be operationalized for 2018. Many of the episodes of care are specialty related. Some are assigned to a single provider leader, where that provider leader gets that cost all attributed to them. And then some of the episodes of care will be attributed to many providers where they will share equally in the cost of that. And that's all going to be calculated by CMS for each episode of care measure. All right, there's still lots of plans being developed for the cost category. In the macro legislation rule, it established it requires the establishment and the use of the classification code sets. So they're developing additional episodes of care measures. They're asking for feedback for that from you folks out there in the real world to give them some examples, especially they want to really try to be able to include care measures that reach out to all specialties, so all specialties can be included. There's also some additional patient condition groups, such as diabetes and COPD. Now, in quality tiering, you were judged on the cost of diabetes care over the year. There was also like coronary artery disease and COPD. Those are no longer going to be separate measures related to the Medicare spending per beneficiary. You saw those on your QRUR report that way. Instead, those are going to be rolled into episodes of care measures, and so they'll be looked at that way. Just a little bit different way of looking at those cost measures. The macro legislation also mandated that patient relationship categories and codes be reported on Medicare claims. They were hoping to have this done before January of 2018. They've got some proposed rules out there and some proposed categories out there, but I've not heard yet that this has been finalized. So what this is they're looking at ways for providers to enter a code on a claim attributing the patient more accurately. They have 5 proposed codes out there. There's like continuous broad, continuous focused, episodic broad, episodic focused, and only as ordered by another clinician. And these all have a definition. Some of them are for primary care, some of them are for specialists, but what your coders will do will enter a particular code that to the Medicare claim, help attribute that patient to the appropriate, what level is your provider that just had that office visit or that procedure with that particular patient. What is that attribution? Are they really the primary care providing all of the continuous focused care? Are they just doing an episode of care and they really shouldn't have that attribution to them? They hope to be attributing a little bit better using those codes too. They also plan to develop risk adjustments on social economic status, and again, they hope to include Part D costs eventually. And these are all plans under development. I have not read enough of the proposed Year 2 rule to know how far they've gotten on those, but those are things to stay tuned for and to watch for. Next slide. This is just a reference slide for you. On the left-hand table, those are the 10 episodes of care that will be used, or episodes of care for the cost measure for the 2018, and what you will see on your feedback reports that come out for the 2017 performance year. The other one is just an example of the 40-plus episodes that they're tracking right now. Those are just some examples of those. If you look at, when I was comparing those, a lot of the ones the current ones are more surgical. But as we get into the more proposed, we're starting to look at more conditions. So again, that's part of their plans to get more episodes of care and condition measures. All right, so moving on to the scoring basics. They're going to score each measure on a 10-point scale based on decile rank, very similar to some of our other categories. It's not a comparison to the average. It's a ranking against your peers. So someone's going to be lowest, someone's going to be highest, and the median is going to be half of the people are going to be above the median and half are going to be below the median. The benchmarks are going to be measures specific that Medicare will calculate from claims. They won't be published in advance because they'll determine them in the year that it's applicable for measuring that. There may be some extra points for improvement after the first year. So like this is what you received the first year, and if you improve on those particular categories, cost measures, there may be some bonus points. And that, again, they did mention that, and I did see some word of that in the year 2 proposed rule. The 20-case minimum there is a 20-case minimum for any cost measures, and the composite score is a straight average of all the calculated standard components that have a 20-case minimum. So if you look at that equation, I tried to put that in an equation showing you how they're converting a cost to a standard score. What they'll do is there will be an analysis by CMS that's going to be expressed in a dollar value, and then they'll compare it with your peers, benchmark it, and then they'll convert it into a decile ranking. All right, so let's look at this in a hypothetical cost scoring example. This always helps me. It makes it a little bit more visual for me. Hopefully this will help you. Again, this is hypothetical. I'm using this as an example as an individual provider that's submitted. If you look at the top, you've got a measures column, a type column, what type of measure it is, how many cases are involved, performance dollars, what it costs you for that particular that MPI for those particular patients that are attributed to that, and then what the median benchmark is compared to your peers for the data that they are evaluating for that performance year, how many points that you received, and then the total possible points. Now again, the total possible points for each measure is 10. That's the highest you can get. So listed are 5 cost measures. There's the Medicare spending per beneficiary. There's the total per capita cost. Everybody's going to get those. And then this particular example shows 3 episode measures. Now, if you look at the total possible points on the right hand, it totals up to 40 because episode number 2 or measure 4, episode 2, there was only 10 cases. So they dropped that one because it's below the case threshold. So the total points that this particular provider can get on his cost scoring would be 40. So after calculating the decile ranking for each measure, so for example, for the Medicare spending per beneficiary, the median was $13,000. This provider cost him $15,000. They gave him 4 on the decile ranking compared to his peers. So they scored all 4 of those measures. Measure number 2, the total per capita cost, he got 4.2. Measure number 3, he got 5.8. He did really well on that episode of care. And when you get your feedback report, I'm assuming that episode is going to tell you the name of what episode of care that is. I just used numbers. And then again, measure number 4, episode 2 is below case, so that was not applicable. And then for measure number 3, he did really well because his cost was below the median, so he got 8.3, or a total of 22.3. So you're going to take the actual score, 22.3, and you're going to divide it by the total possible score of 40, and you get the percentile, which is 55.8%. Then you're going to multiply that by the maximum cost category scoring weight. So if it was 2018, it will be 10% to get 5.6. So if it was 2019, that you would multiply it by 30. So it's 10%, so we're going to get 5.6 for the total final score for cost. And you'll add that score, that score will be added to the other 3 performance categories to get the final score for that provider for their final MIPS score to tell them where they fall for the program. Just a quickie on the special cost scoring standards for the MIPS ATMs. Again, MIPS eligible clinicians participating in an MSSP will not be assessed on cost, and there's no reporting necessary for you. So what will the 2017 feedback reports tell you? Well, we expect it to be similar to the cost measures exhibit on the QRUR report. In the first years of MIPS, the cost category is weighted at 0, and in the MIPS final score in order to give the clinicians this experience with receiving and understanding their feedback reports based on cost measures. Although an estimated 80% of overall healthcare costs are attributed to the decisions made by clinicians, these same clinicians are often not aware of how their care decisions influence the overall cost of care. So the cost category of MIPS provides an opportunity for informing clinicians on the costs for which they are directly responsible, as well as the total cost of their patient care. Now, CMS intends for the information on the cost feedback reports to be actionable by the clinicians in targeting areas for improving the delivery of high value care and resulting in smarter spending and improved patient outcomes and experience. You can see here a list of things that they are hoping that you'll be able to look at, and like your referral patterns, your care coordination efforts, how you're managing your care outside your office, like are your patients going to the emergency room? What are your post-acute care partners doing? Really, the key to success in this category is really to keep your patients going back to your office. When they look to you for care, you have better control over who else will they see, and you can make more careful choices about the referrals to clinical partners who share your approach and are mindful of controlling costs while providing good care. Okay, so now that you're all experts on the cost category, let's just connect the dots. So based on the performance in 2017, an EC will see a positive, neutral, or negative payment adjustment of up to 4% through your Medicare payments for the Medicare Part B covered professional services that you'll furnish in 2019. This adjustment percentage grows to a potential of 9% in 2022 and beyond. So in addition, during the first 6 months, 6 payment years of the program, or from 2019 to 2024, MACRA allows up to $5 million each year in additional positive adjustment for exceptional performance. Now again, this is not money, this is money that's been set aside by Congress. This is not part of the budget neutral. That's really important. A few things that you need, just 2 things that you really need to know. You want to submit the data to earn 3 points to avoid the negative payment adjustment. Now, or you want to strategize to earn 70 points or more to gain access to the $500 million bonus pool for exceptional performance. That's what I think, the 2 things that you want to think about when you're strategizing. What are we going to do? Are we going to try and just avoid the negative penalty? Then you just need to submit something to get 3 points. If you want to try to get some of that exceptional bonus money, then you want to try and earn 70 points, and you want to strategize that way. These are 3 ways to earn the 3-point minimums: reporting data for 1 quality measure, attesting satisfactorily for all ACI base measures, or completing 1 improvement activity and documenting that and submitting that. Reasons to go for full participation. 2017 is going to be the easiest year to assess the $5 million bonus pool. Anyway, that's what CMS predicts. Also because of public reporting, this information is going to go up on hospital or physician office compare, and patients or beneficiaries are getting smarter and smarter, and they're going out and looking as they're starting to compare what providers am I going to use. Also, it's going to set you up for future success. So let's bring it all together. For 2017, the quality points are worth 60. ACI is worth 100. Well, it's worth 60. You can get a total of 60 points. It's worth 60%. ACI, you can get a total maximum of 100 points, and it's worth 25%. And improvement activity, total points is 40 for full credit, and that's at 15% for the final score. And I thought we'd bring it all together from our MIPS Survive and Thrive Performance Category Series, our quality hypothetical scoring examples, our first one received, our EC received a 49.9, For AC, he received 20 points, and for the improvement activity, he received 15. Cost was 0. So our hypothetical example for our eligible clinician received final score of 84.9. So he reached above the threshold of 70 points. He will be receiving a positive adjustment. We don't know what that is. It's all budget neutral. That will be determined depending on where everybody else falls. So he's very eligible for the exceptional performance bonus. A minimum of an additional 0.5% is guaranteed with that. These are some takeaways. I'm not going to read these to you. Just things that we've talked about over the last few webinars. But I want to save some time for Q&As. This slide just tells you full service QPP Technical Assistance. There's lots of us out there willing to help you determine kind of what size you are. Reach out to either Michelle or myself. We'll get you to who is the best expert for your particular situation and scenario. These are some resources on the QPP website, and if you click on those links, they'll take you right directly to the resources. And we really appreciate you joining us. We look forward to hearing back from you. We're going to open the lines for any questions you might have, and also I just want to remind you that you will be getting a survey asking about how we did. Was this helpful? Please fill that survey out. Give us any suggestions you have. We have to do that for our contract, but also we want to know what you're thinking, how we can help you best, and what we could be presenting on in the next couple of months. Thanks. I'm going to turn this over to Michelle to open up for questions.
The leader has unmuted your line.
Okay, I believe the phone lines are open, so please feel free to ask any questions you may have, Sandy or myself.
Hi, this is Jody from the Grundy County Memorial Hospital.
Hi,
I was hoping for some clarification on back under the improvement activity section, the special scoring for small, underserved, and rural areas. What are they using to define rural areas? Is that the like a federally qualified rural health clinic, or would that be critical access hospitals? Have they given any specifics to what defines rural?
That's a great question, Jody. So the rural counties are defined on the health professional shortage areas, or HIPSA, and there's a website, and I believe it's HIPSA.gov.
You know what, Jody, I have a link to that where you go in and you plug in your zip code and your address and stuff, and it'll tell you if you qualify. So I think I have your contact information. I think I've talked to you in the past, but why don't you send that question to my email, and I will send that link to you. Okay?
Perfect. Thank you.
Anybody else that is wondering about that too, just send the question real quickly to Michelle or myself, and we'll send the link to you. We have the direct link.
Thanks, Jody. Do we have some other questions out there?
Hi, this is Anita Sportfager with Pella Regional Health Center.
Hey there.
I'm wondering, do you know, we're a critical access that bills under Method 2 with a lot of our clinics, and do you know if they're going to be able to include Method 2 billing claims in this cost category? With the QRUR reports, we've had issues the last couple of years because they did not include Method 2 claims.
Right. I mean, my assumption will be yes, because Method 2 is included in determining your eligibility. But that is a great question, Amanda. If you want to formulate that question a little bit more specifically and send it to me, I'll send it right on to my CMS help desk and see if I can get a little bit clearer answer to that.
Okay, that would be great.
Okay, thank you. And this was Sandy, by the way.
Hello?
Hi there.
Hi, my name is Molly Daum from Chicago, Illinois, and I just saw an article yesterday saying that Medicare was going to increase the number as far as if you had to participate, if you had 90,000, was it 90 patients?
Yeah.
Something. Did you bring that up at all?
We did not bring that up, but I'm glad you did, Molly, because that is in the proposed rule that they are looking to increase the low volume threshold from what it is now from 30,000 in Medicare Part B allowed charges up to 90,000 Medicare Part B allowed charges and more than 200 unique Medicare patients instead of the current 100 Medicare patients, those unique patients.
You have to remember though this is proposed.
Right.
If it does get finalized, the comment period out for this is through June 21st. If it gets finalized, it won't take effect until the 2018 reporting period. So the low volume threshold stays as it is now for 2017.
Okay.
Okay. Does that help?
It does, yes.
Okay, yeah. But that could be a real big win for a lot of the rural health clinics, the critical access hospitals, folks that want to do individual provider reporting. But again, that's only proposed, and Michelle and I are hoping to be able to read that legislative act. It just came out on Tuesday, and do a webinar on what some of the proposals are here in the next month or so, too.
Okay, thank you.
You're welcome.
And I'm just typing in on the chat function, if you do have access to that hits the search just in case anybody else, I'll do the data warehouse .hrsa.gov. Data warehouse is all one word, .hrsa.gov. So I have that out there too, and we can also reply to any emails on that as well if you aren't able to see that. Okay, well, we do have our contact information here, and please feel free to reach out to either one of us, both of us. We actually sit right next to each other, which is awesome. These slides and the recording, the slides will be out there probably yet today, and then the recording, they're very quick about getting those out for us, so I look for that to be early next week at the latest. So we'll make sure we get those wrapped up for you and there, so if you want to repeat a section or, give it to a friend, please do so, and that's on our intelligentqpp.com website. Okay. Well, thank you so much, everybody, for joining us today. And again, we appreciate you filling out the questionnaire that'll be coming your way. Have a great day.